Good evening, everyone. My name is Kathy Pierce, and I'm the Director of Programs at the American Nutrition Association, the ANA. The ANA would like to thank Bragg Health Foundation for their support of our 2018 Global Webinar Series. Learn more about their mission to inspire and educate people to adopt a healthy lifestyle through optimal nutrition, exercise, positive attitudes, and spiritual wellness at bragghealth.org. We'd also like to thank our sponsor, Standard Process, for their support in bringing this webinar to you. Visit their website, standardprocess.com, for more information about their positive impact on health and wellness. The American Nutrition Association is very pleased to be hosting Dr. Andrew Heyman tonight to explore the underlying causes of chronic inflammatory response syndrome and the nutritional interventions that play a crucial role in this condition. Let me take just a moment to tell our audience about the ANA. We're a nonprofit organization which for over 40 years has been on a mission to promote optimal health through nutrition and wellness education. We educate the public and professionals in many ways, including hosting world-class nutrition programs such as this one tonight. We encourage all of you listening this evening to visit our website at theana.org for an abundance of nutrition information, resources, and upcoming webinars. Join the ANA as a member and help us continue to bring these nutrition luminaries to you. The ANA would like to thank Now Foods for providing the technical assistance that allows us to present our webinar series. Find them at nowfoods.com. And now we are honored to introduce Dr. Andrew Heyman. Andrew Heyman is a medical doctor and internationally recognized expert in integrative medicine. He is currently the Program Director of Integrative and Metabolic Medicine at George Washington University. Prior to assuming this role, he spent 16 years at the University of Michigan, serving to build one of the largest and most successful academic-based integrative medicine programs in the United States. He also serves as co-chair for medical education of the Metabolic Medical Institute, which trains professionals in integrative, metabolic, and functional medicine. Dr. Heyman received a master's in Health Services Administration at the University of Michigan School of Public Health and administered the University of Michigan's Complementary and Alternative Medicine Research Center, where he was responsible for a $7 million NIH grant to research alternative therapies for cardiovascular diseases. His research interests include neuroinflammation and biotoxic exposures, the stress response, neuroendocrinology, cardiometabolic disease, men's health, and clinical outcomes research. Dr. Heyman will answer a few previously submitted questions at the conclusion of his presentation. And welcome, Dr. Heyman. It is a real pleasure to have you with us today.
Thank you, Kathy. It's a pleasure to be here with you and your audience, and an honor to be a part of the premier organization responsible for educating our global community on the connection between nutrition and health. I think this is a really important topic, one in which it has become a central operating idea in my own clinical practice, and as I have further matured with respect to sort of my understanding of the underlying common causes of illness, this subject continually surprises me in terms of how common it is, how debilitating it can be, and how often these types of patients are showing up in our integrative and functional medicine practices. So I want to thank everyone for inviting me and giving me a chance to discuss this topic in detail. I would also say as a word of note that this is a complicated area of medicine, and therefore this information is quite dense, both in terms of the underlying science as well as the clinical approach. I'm happy to answer questions moving forward into the future if any of our listeners are confused at some point. But bear with me, because I think that this is one of those areas that we can all benefit from as integrative providers. So what is the chronic inflammatory response syndrome? By definition, like most chronic illnesses, it lasts at least 6 months. In addition to that, it is driven by an inflammatory process that mostly is generated within the innate immune system. As many of your listeners should recall, the immune system is divided into two large components, the innate and the adaptive or acquired. The innate immune system is responsible for early detection of vectors and threats. And in this particular patient population, there is a defect that is genetically mediated with respect to the ability of the innate immune system to hand off that early immune response via antigen presentation to the adaptive side with respect to T cells and B cells. And so by definition, this patient population remains essentially stuck in this chronic inflammatory process where there is no handoff and therefore no ability to really resolve the phenomenon over time. It is a syndrome in that regard in the sense that the inflammation leads to a variety of physiologic problems and therefore a long list of symptoms at presentation. And so what are some of the defining clinical features? We see abnormal proteomics. There is a language to this. These are new or relatively unknown immune markers and neuropeptides that become abnormal in the setting of this chronic inflammatory response. I will go over that in detail. There's also an associated abnormality in transcriptomics, meaning that the underlying genetic behavior in this patient population is also abnormal. Not so much that the genes themselves that are present are defective or have some sort of inborn impairment, but that in fact their expression is altered over time, which leads to the fundamental underlying phenomenon of chronic inflammation. We also see as a result of this abnormal regulation of immune function. So this inflammation persists, which leads to a variety of functional as well as structural abnormalities in the patient. And then also there's an abnormal regulation of hormone function. For those of you who spend your days focusing on cortisol abnormalities or thyroid problems or reproductive hormone imbalances, cardiometabolic issues, weight gain, obesity, all of that is tied into this particular underlying immune phenomenon as well. And by virtue of this then, therefore, these diseases are all around you. How common is it? Well, about 22% of the population are born with HLA sequences on chromosome 6, which confer that impairment in the innate immune response, meaning they have poor antigen presentation. They remain stuck in that chronic inflammatory state. This is 40 million people in our population. The common clinical feature is fatigue. And so if any of you in the audience sees patients that are complaining of fatigue, there's a very high likelihood that underlying your clinical picture, underlying your functional lab abnormalities, underlying even some of the more standard conventional diagnoses is likely this engine that is sort of driving that imbalance. It is extraordinary how common this illness is, and even to the point when, as we began exploring this patient population and collecting data, we were continually surprised by the frequency with which these patients were showing up in our practices, almost to the point where we began questioning our own data sets. But we know that there's a high penetrance in the general population because of these HLA alleles. So this is one of the words of caution that if you see patients with common presenting symptoms, which I'll cover, you have to ask yourself the question, is this an individual who suffered a biotoxic exposure? And what sort of biotoxins might comprise this patient population? So, for example, it could be a tick-borne illness. We know that our standard testing for Lyme disease is pretty poor. Generally speaking, our two-tier testing with the ELISA and Western blot captures 30 to maybe 50% of this patient population. And there's a real failure, therefore, to detect when patients are actively infected with Lyme disease. Now, my clinical practice is in Northern Virginia, and as we began to make links between this chronic inflammatory response and the presence of Lyme disease, I thought, in fact, that many of my patients who were being evaluated by us were likely infected, and I was wrong. I did not realize that Lyme and tick-borne illnesses is just one biotoxin among many potential triggers that patients seem to be suffering. So one of the other common triggers, and maybe an even more important one to some degree, is a water damage building. So mold exposure, MVOCs, VOCs, bacterial fragments that potentially are living in the structure, any one of which or all of which can also confer the same inflammatory process, the same symptom list. And so that's one of the confusing aspects of this illness, is that there's a variety and potentially a large variety of biotoxins that can turn on this inflammatory process. So there are diagnostic challenges that arise as a result. The first question you have to ask yourself as a clinician is, does this patient meet criteria for this phenomenon? And I will go through that in detail. The second question is this a result of a tick-borne illness? So even if you define the inflammatory process and you make the diagnosis, you always have to ask yourself the question, what's the trigger? And the corollary to that is the trigger still present? Because one of the features that we've been able to identify is that in the susceptible population, in the 20%, if those HLA alleles are present, once the biotoxin turns on this inflammatory process and the genes essentially are activated and we begin to see these abnormal sequences of genetic expression, those alterations down to the genome do not return to normal even when you remove the offending exposure. If you give your patients antimicrobials, whether it's antibiotics or herbs, if you have them remove themselves from a toxic building, for example, if they're in the 20%, we will see these alterations in gene expression that persist over time, and regardless of whether or not the exposure is still present. So I find this answering the second question even harder in terms of what turns this on and is it still present. The third component is if the patient doesn't have common exposures like mold or tick-borne illness, what is or was the original exposure? And sometimes we just don't know. We still go about the process of treating the patient, and we're not sometimes sure exactly what the offending agent is. We hope that it's something in the past. Again, there's 30 entities that we believe now can trigger this very specific type of inflammatory response. These are somewhat hard factors to measure. There are some companies now that are doing a better job in terms of swabbing a physical environment to detect some of these actors, but we always have to be very vigilant to ask the question, why is this patient so sick in the first place? In addition to that, it's a bit more straightforward in terms of measuring the biomarkers themselves, the proteomic profile as we call it. There are about 25 papers that have been published in the literature, some of which is from our research group, in addition to the rest from other research groups as well. We have over 4,000 patients in our database. This is across clinical sites, and we always use ancillary data to help confirm the diagnosis, whether that's cardiopulmonary exercise testing, pulmonary function testing, volumetric brain scans, genomics and transcriptomics, as well as other functional tests looking for disorders such as gastroparesis, gallbladder dyskinesia, chronic motility problems in the GI tract, T regulatory cell abnormalities, as in addition to the presence of the proteomics, the HLA sequences, and something called a visual contrast study. Those last three are much easier to obtain, and most practices will be able to measure them. Our protocols have also been shown to correct all of these issues, meaning we're able to turn off the inflammatory response. We're also even able to undo the abnormal genetic expression, as well as some of the CNS atrophy that we see in this patient population. In addition to this, I really want to emphasize that there is no difference in the way that these patients present due to their biotoxic exposure. So certainly mold is one, but we also know dinoflagellates and apicomplexans and cyanobacteria. There's a long list of bad actors that humans can be exposed to. And it's the meeting of the biotoxin along with a predisposed patient who has these HLA alleles that is what causes the disaster. So some of the tools that we use to make the diagnosis include a symptoms cluster analysis, as well as supportive evidence, as I mentioned, pulmonary function testing and diffusion capacity. We can see in some patients interstitial lung disease, We can also detect cardiopulmonary problems, especially elevated right-sided heart pressures, pulmonary hypertension. In addition, one of the more insidious aspects of this illness is that as the proteomics become more abnormal, we also see constriction of capillaries. And so there's poor peripheral blood flow, decline in VO2 max, loss of exercise tolerance. And then one of the hallmarks of this illness is the neuroinflammatory process. This is ultimately a brain-on-fire phenomenon. So as much as we can see these ubiquitous changes throughout the physiology, one of the most insidious components is the neuroexcitation and neuroinflammation that leads to disastrous consequences in this patient population. Hence, we started applying something called NeuroQuant, which is a volumetric brain scan. We've been able to show brain-related changes due to the inflammation. And if left unchecked, these brain-related changes can be persistent. Said another way, the inflammation that's present in this patient population can lead to ultimately a brain injury. And make no mistake, this injury is real, it persists, and it creates the chronicity around this patient population in combination with the abnormal transcriptomics, meaning the abnormal gene response that we see. So at every level of illness, whether it's at the genomic level, the physiologic and immunologic level, or the organ structure level, this is an illness that has full impact. And so we have to be very respectful of this patient population, even though the defining feature is just fatigue, which seems like a very almost innocuous to some degree presentation. We also need to show that our interventions work. And thank goodness we have been able to do that in a couple of randomized controlled trials, and we continue to refine that process. Here's our symptom clusters. There are 13 categories of symptoms. To make the diagnosis, in part, patients have to have at least one symptom in 8 of the 13. And if you notice, as you scan this list, fatigue, headaches, aches and pains, sensitivity, respiratory issues, abdominal pains, and one of the big ones, I think, is the executive functioning and cognitive memory deficits, word-finding difficulties, confusion and disorientation, constitutional abnormalities with mood swings and appetite issues and sweats and temperature regulation problems. Interestingly, one of the big consequences of this illness, too, is significant weight gain. And so if you have a patient that's presenting with fatigue and brain fog and memory decline, but also a 30, 40, 50, 60-pound weight gain that seems to be inconsistent with their lifestyle choices, you have to think CIRS. So if you step back and you look at the list, weight gain, fatigue, cognitive issues, headaches, digestive complaints, so on and so forth, these are very common symptoms. This is, for me as a family physician, I would see these every day in my practice. And I just did not have the toolkit to address and understand the underlying immunologic phenomenon. I would also argue from the functional perspective, the other labels that you might be applying, adrenal fatigue, leaky gut, hormonal imbalances, toxin exposures, meaning heavy metals and chemicals, that as you go about the business of trying to balance those phenomena, if you're not making progress, you have to consider CIRS as another doorway to look through. So the impact on the brain is profound, and it's driven by this inflammatory response regardless of the exposure. We know that these inflammatory proteins bridge the blood-brain barrier because of this innate immune activation, and as a result, we see alterations in brain-produced neuropeptides, which begin to change how our bodies function in a very fundamental way. So we have several randomized controlled trials that we've published that articulate the diagnosis and treatment process. This is all before we started applying next-generation sequencing, looking at the transcriptomes of these patients, and that's genomic jargon to say we're actually measuring the RNA production off the DNA. We're not just looking at which DNA is present, sort of like a 23andMe. We care a lot more about gene activity and gene response. What are the genes doing in the setting of this illness? The way to measure that is to assess for RNA production. It's sort of the difference between understanding what are the components of a guitar, which is our genetics, as opposed to what's the music that's being played. That's the genomics and the RNA. So we've established labs as a baseline, and they also help us guide therapy. We have protocols for each step that occur in a sequence. We suggest not skipping steps as you unwind and undo this complicated illness. And the final step is something called vasoactive intestinal peptide. This is a nasal spray that we recommend. It does the end correction of the residual problems that we see throughout the physiology. But we also know that if you don't deal with the early or initial issues in this patient population, the VIP, however magical, does not work very well. So we also know, therefore, that even as the labs normalize, there's still typically an underlying set of genomic abnormalities that persist, as well as the brain-related changes, and that there's therefore always the potential, especially if the patient is going through therapy, that they can have a re-exposure that further ignites the inflammatory response. These patients are not done even when their blood labs normalize. So here's the biotoxin evaluation process. We go through an initial screening. We give them the questionnaire for the symptoms, the 13 categories. We look for at least 8 of 13. We then run our labs for proteomics. We suggest some functional labs as well. We also order for HLA sequences, and then a set of infectious disease markers. We have patients complete a visual contrast study, a history and physical and exposure history. We then look to verify whether or not these patients meet criteria. Do they have a known exposure? Have you ruled out other causes? Do they have positive symptoms? In addition to that, we want supportive objective evidence. Have they, and this is 3 of 6 of these. So have they failed their visual test? Do they have the genetic predisposition? Do they have abnormalities in their proteomics, which I'll cover? And then we look to confirm, meaning as we treat the patient, are they getting better? And then we also go about the business of diagnostic refinement, meaning what is the biotoxin? Is it Lyme? Is it mold? How do we detect for these things? And then do we have additional supportive clinical data, cardiopulmonary testing, the brain MRI volumetric scan called Neuroquant, and then the transcriptomics. Some of this any practitioner can get easily. I would say that the transcriptomics is really the only thing that can't normally be ordered. We still run it as part of our research, but it's not something that's widely available, at least yet, and it's a very expensive test, unfortunately. But we begin with this notion of brain inflammation. We know that as a person is exposed, it is a brain on fire phenomenon. There's a cytokine storm that occurs. And so we ask the question, is there some sort of global test that we can do to assess for this central nervous system phenomenon? And it turns out that there's this very reliable, very simple visual contrast study that was developed by the U.S. Air Force decades ago to detect when a community had some sort of biotoxic exposure. And we know that it's incredibly reliable, especially beyond day 4 of the biotoxic event. And what it's really measuring is inflammation in the optic nerve. And specifically, it's asking the individual to answer questions related to color discrimination. It turns out that the more inflamed the brain becomes, the more we lose our color discrimination capacity. It's not visual acuity, it's not clarity of vision, it has to do with color assessment. And so we know that when patients are treated for biotoxins without any additional support, meaning, for example, if you have Lyme patients that you give antimicrobials to, 20% of that population will ultimately fail the visual test beyond therapy. This data for us and in the literature has been very, very consistent. So what does the visual contrast study look like? This is a result of one of my patients, and you can see on the bottom a fail. So what the grid is assessing is 45 gray circles with lines in them, and the patient is asked to cover one eye and answer questions about 45 circles and then cover the other eye and do the same thing. And then they get an immediate result. If they fail this test and the patient has 8 categories of symptoms present, we have a 98.3% sensitivity that this is a biotoxic exposure. So all you need to do is ask about the symptoms, have the patients complete the visual test, which takes 10 minutes, and then you basically have an answer. Now, we also know about 9% of the patient population, no matter how inflamed they are, will pass the visual test. So it's not hard and fast. As I said, you need 3 of 6 of objective markers, and this is one of those 6, but many patients will fail the visual test. Now, is there predisposition? Another one of the 6. And so here is the allele sequences that we look for. There are 3 multi-susceptible alleles. This is a test that you can order through some of the major lab providers. It's called HLA-DRDQ, and you'll get a series of nomenclature reports based on the 2 genes that are present. You have to do a little bit of recoding to say, okay, this is the string that I see. There is what we call a Rosetta Stone related to the HLA, so when you get that lab report back, you're able to interpret based on whether or not this patient is susceptible. This is the Rosetta Stone. This is how you interpret the results, so you have to do a little bit of work in that regard. Some alleles are mold-specific, some are Lyme-specific, but we know, again, that about 22% of the population carry these HLA sequences that make patients very, very sick and turn on this chronic inflammatory response. Now, once that occurs, this becomes the new language that we've had to develop around this clinical phenomenon. So it's not inflammation that we typically understand. It's not CRP, it's not SED rate, it's not even TNF-alpha or IL-6. We're looking at specifically innate immune markers that have been upregulated in the setting of a biotoxic exposure. And you have to be very careful how you measure these things. C3A, C4A, MMP9, TGF-beta1, as well as the commensurate hormonal, potentially autoimmune abnormalities, in addition to the capillary hyperperfusion phenomenon. And there are some other factors that become important and therefore we need to treat, including commensal infections, which I'll discuss. So here is the process by which the body begins to unravel in the setting of the exposure. If you looked on the left-hand side, there's a biotoxic event, and in the 20%, we begin to see expression of cytokines in the central nervous system, and this establishes sort of the secondary and tertiary consequences. So what we begin to see are alterations in the hypothalamus, in the posterior hypothalamus, destruction of leptin receptors. This is why appetite becomes dysregulated and patients start gaining lots of weight. So there's a leptin resistance, a central leptin resistance that occurs, in addition to abnormalities in production of neuropeptides, including VIP, melanocyte-stimulating hormone, and arginine vasopressin. MSH is probably the most important hormone you've never heard of because it's a master control hormone. It regulates sleep and melatonin. It also supports endorphin production, which is why these patients have typically chronic pain. But interestingly, it also controls tight junctions in the digestive tract, so this is why these patients have leaky gut. That often doesn't resolve when you do your food testing and try and seal up the gut lining, because if you don't fix the brain, you can't fix the gut. These patients also have abnormalities in hormones, so discordance in their cortisol and ACTH ratios, upregulation of aromatase, problems with water balance and antidiuretic hormone, and in addition to that, impairment in the immune system, which means the presence of resistant staph infections in the deep nasal passages. The MARCONS, which is an acronym for the resistant staph, is very insidious. So once MSH begins to drop, if there's staph in the person's environment, especially resistant staph, it will colonize the deep nasal passages. It does not typically cause sinus symptoms, but it will release a very small compound called a Biotoxin that further inflames and damages the brain. This is a bad actor that has to be dealt with in the setting of this illness. Beyond that, we see release of hypoxia-inducible factor, which triggers vascular endothelial growth factor and TGF-beta1, which begin to lead to the capillary constriction and muscle fatigue and interstitial lung disease and shortness of breath and arrhythmias. This is ultimately a disaster in the cardiopulmonary circuit. We also see triggering of autoimmune antibodies, including antigliadin, cardiolipins, in addition to triggering of the alternate complement cascade. So we see production of C4A and C3A, which further leads to brain fog, fatigue, and capillary hyperperfusion. The C3A tends to go up in the setting of just a bacterial infection or production of lipopolysaccharides in the gut, and then a host of additional inflammatory proteins like MMP9, PI1, so on and so forth. So you can see that this is a ubiquitous response throughout the physiology that ultimately leads to not only the feeling states of being miserable, but shifts in the immune system, hormones, digestive tract, cardiopulmonary system, so on and so forth. So here are the normal ranges for each of these markers for VIP and MSH. Here we have TGF-beta1 and C4a. These are typically reliable inflammatory proteins that are often elevated in this patient population. The C4a is the only one where we've seen some specificity with respect to the amount of inflammation linked to the actual biotoxin. All the others just tend to become abnormal, but we can't really guess what the exposure was, except potentially the C4a. So what we have found in our data sets is that patients who've had a Lyme infection, their C4a tends to be 6,000 to 8,000. But in a mold population or water damage building, we tend to see a C4a of 12,000 or above. So if you have a patient that's complaining of brain fog and their C4a is 20,000, you can pretty much guess that it's a mold exposure or some sort of damage to a structure that they're spending time in. Again, we also see some anti-gliadin antibodies, abnormalities in ACTH and cortisol ratios, abnormal expression of VEGF, either high or low. Typically, VEGF is high early in the illness and low later in the illness process. Also, unfortunately, the blood becomes sticky, so we see the presence of anticardiolipin antibodies, even D-dimer elevations, von Willebrand's factor, and they also have water control issues. So these patients often are urinating frequently, they're hypovolemic, they cannot maintain a normal water volume, and therefore they tend to have static shocks as well as constant thirst, and it's really troubling for them. We also see expression of MMP9. This is a matrix metalloproteinase that is responsible for degrading connective tissue. So we begin to see involvement of tissue and joint destruction in this patient population. And then one of the most troubling is the weight gain because of the leptin resistance that starts to develop. So as you're building your data set on symptoms, visual testing, proteomics, again, you need to ask yourself, is it Lyme, is it mold, is it something else? If it's a Lyme patient population, we use nanotechnology, which was developed through George Mason University. I think this is a very reliable test. It's based on trapping nanoparticles in the urine for an actively infected patient population. And so we're actually looking for bits and pieces of bug in the urine. It's called a nanotrap. And in particular, a highly conserved protein called outer surface protein A. This is a negative result for one of my patients. In addition to that, if you're thinking it could be water damage building, I'd suggest against doing air sampling and using swab kits based on PCR analysis. This was developed by the EPA many years ago. There's something called the ERMI test, the Environmental Relative Moldy Index. There's a company or two that now sells these test kits for patients' homes. And then there's a more refined version called the HERTSME2, which we actually think is proving to be even more reliable. The data on HERTSME and ERMI testing is actually pretty good. And this is what an ERMI swab kit looks like. So in the top half, there's a variety of bad mold actors, and then the bottom half are thought to be non-pathogenic forms of mold. And then you get a sum total score for the ERMI. If you have an ERMI above 2, then this is likely a sick building or a sick home. And while it doesn't tell you where the mold problem is, it just tells you that this home has a mold problem. You may also want to consider some functional tests. This is sort of the language that I think this community probably typically speaks. So you can evaluate their saliva cortisol pattern, food sensitivity, functional GI patterns, lipopolysaccharides, diamine oxidase, mast cell activation, and even blood-brain barrier testing. These, to me, are all secondary to the core measurable panels for proteomics and visual tests. But if you want to add these in to kind of round out your thinking, you should go ahead and do that. In addition, I had mentioned the brain-related changes in this patient population. This is a neuroquant result. You can see columns here with percent changes for the left and the right. The two columns just to the inside of the outer columns. And we measure key areas in the brain. And what we found is something really striking, that even though symptoms might be identical for various biotoxic exposures and labs might be essentially the same except C4A, the brain-related changes were unique, and that we did not expect that. This is specific to mold. So we see forebrain parenchyma changes, cortical gray matter, hippocampal abnormalities, all swelling, but then we also see atrophy or dendritic volume loss in the caudate. That is very unique as a pattern to mold, and quite different for Lyme. So cortical gray matter, hippocampus, and caudate are normal, but we see a atrophic forebrain and putamen and an enlarged thalamus and cerebellum. And here's our mold scoring system. So you can look at those 2% columns. You score the left and the right. You need to have volume loss present, so a small caudate, in addition to some of the other changes. Anything above 4 is pathognomonic for mold-related changes. And here's our scoring system for Lyme. And again, you need to see atrophy in the putamen as part of the diagnostic criteria. So as we go through this process of working the patient up and confirming that this is a biotoxic exposure and realizing that these are such common complaints, it will change your life forever. I don't think you'll ever go back to the way you normally thought, whether if you're originally a conventionally trained provider or you consider yourself more integrative and functional, and you realize that you have this kind of irreducible nugget of patients that no matter what you do in terms of changing their diet and recommending supplements and hormones and whether or not you're a prescriber for medications, that they just stay sick. You can't get them to lose weight. Their energy never really improves. Their mood isn't stabilized. And you get a little frustrated. You think, I'm not so sure I know what's going on. Maybe I need a different or new functional test. And I would argue we're probably looking in the wrong pot, that you need to change your frame of reference and start speaking the language of proteomics and CIRS and become comfortable with that. This is new science that is becoming very well established and validated, but it's quite exciting because it gives us a whole new way of looking at this patient population. So again, what are the treatment challenges? Well, you need to eliminate the exposure, correct the inflammatory response, repair the damage to the brain, and restore normal genomic activity. So you might say, well, how do I do all that? If it's not just about killing Lyme or getting people out of a moldy environment, what's the process by which I'm going to treat these patients? Well, I had mentioned the 2 randomized controlled trials, and these are well published. There's a stepwise process to reverse these issues. But with that being said, this is a process that I don't think really appeals to the integrative crowd. Much of this is based on prescribing conventional medications in unconventional ways, but I also think that in some ways it lacks a thoroughness in terms of really, truly, and fully getting these patients better. So instead, what I put together is an expanded treatment protocol, still relying on the core proven features of how we unwind this illness based on those 2 randomized controlled trials, but I've given options to you as a treatment provider. So here we have the stepwise process. We start with the foundations of the patient in terms of diet and stress management and sleep support. We also begin with some strategic lipid replacement with phosphatidylcholine in addition to a balanced oil and some electrolytes and wheat germ oil. We like this lipid approach because we know as the patient becomes more inflamed, they're more and more damaged. We also seek to reduce that neuroinflammation immediately. So we use an extract of ginseng called RG3 combined with nicotinamide riboside. This is a compounded natural agent. Now, all 3,500 PCCA pharmacies are able to make RG3. It's a very, very potent molecular compound extracted from ginseng that is an antidote to the neuroinflammation that you can start patients on right away. If you don't have access to that, we do curcumin, a high extract curcumin, in addition to resolvins. Resolvins are small molecular compounds that are used to turn off inflammation in the digestive tract. You then also have to consider the exposure. Am I going to treat the infection, or is it mold? So once you deal with sort of shoring up the patient and dealing with the offending biotoxin, we then go through the process of reducing the toxic burden, establishing metabolic balance, and focusing finally on resolution and repair. So let's talk about foundations very briefly. Low inflammatory diet, stress management, which I'm sure you all know how to do, additional sleep support because this is a brain on fire phenomenon. So anything you can do to get your patients to sleep is really, really important for rest and repair. In addition to that, again, we get on aggressive lipid replacement with phosphatidylcholine, some balanced oil for omega-6s and 3s, some electrolytes so the cells start to communicate more efficiently, and then some polycosanol, which is essentially a structural fat, which helps to reestablish normal cell membrane integrity, and then also reducing that neuroinflammatory response with the RG3 nicotinamide, curcumin, and resolvins. If you can't do the RG3, that's fine. Just do the curcumin and resolvins. In addition to that, we suggest that a patient, if it's a mold-related issue, stop eating mold. And just for those of you who are a little confused, mold is not candida. They're both fungal elements, but mold is a bit more troubling and problematic for patients. In addition to that, mold does not really successfully grow in humans. We just breathe in the consequences of it, as opposed to candida, which is in some ways a commensal, but if it overgrows, it can cause problems. We don't use antifungals to treat mold. It just doesn't work. It's a different organism. But patients can inadvertently be also consuming mold in their diet. So some of you might be aware of a urine test for mold factors. This is a test that I often see in patients when they come into our practice. All that test is really doing is assessing mold that's being consumed in the diet. It's not that the mold is actually growing in the patient. So there's a real confusion about that test, which needs to be better articulated. What do we do about the exposure elimination? If we're dealing with Lyme, there's a couple herbs that I recommend. Artemisinin is really important because it's a potent antiparasitic. It's been well studied in protozoan parasites. These are intracellular organisms which can cause misery in patients. The big one being Babesia from the tick-borne illness. In addition to that, it's been studied in a variety of helminths as well. And we know in certain parts of the world, patients are exposed to these helminths. And so there's some nice clinical outcome studies on artemisinin. It also has some antiviral properties to it because oftentimes ticks carry viruses as well, which I think is a nice added benefit. And there's several open randomized controlled trials applying artemisinin or extracts of artemisinin. And there's even prescribed medication like Mepron and Malarone that are essentially derivatives of artemisinin. But as long as you have access to a good quality artemisinin product, you should have nice outcomes. There's also a less well-known botanical called myrrh. This is a resin that comes from the Commiphora, basically out of Northeast Africa and Arabia. It's been mentioned for a couple thousand years. There are several clinical studies that have been published showing real advanced treatment for parasites. It also goes well beyond the gut to getting into peripheral tissue, so I like myrrh as well. Myrrh is typically pulsed in an on and off cycle, and it's been studied in a variety of types of infections. So 3 to 9 consecutive days on an empty stomach, and then you break for 4 to 14 days. The daily dose of myrrh used in trials corresponds about 2 to 3 grams of the herb itself. So once you get beyond the Lyme treatment phase, you're starting to gain control. You're reducing inflammation, replacing lipids, and dealing with the exposure, whether that's Lyme or you've done your ERMI or HERSMI swab, and you say, okay, you have to start the remediation process. Well, now what? So you have to focus on reducing the toxic burden. And this is critical and important and not well understood. The type of inflammation that's generated in this patient population is part of enterohepatic circulation. So the inflammatory proteins are produced in the peripheral tissue. They're then absorbed by the liver and displaced into the digestive tract, being emulsified in the bile. And there these inflammatory proteins sit. So you want a biotoxin sequestrant, a bile acid sequestrant. You have several choices. Cholestyramine being the standard. This is a prescribed medication. It's very potent as an anion binder. But you also have a natural alternative. It turns out okra, of all things that I found in the literature, also can work as a bile acid sequestrant. It's just not as potent as cholestyramine. They both need to be done 30 minutes before meals and away from other agents, at least an hour, because you want these agents to be binding just the inflammatory proteins that are collecting in the digestive tract. Okra works even better with soluble fiber. Its activity increases to about 35 to 40%. of cholestyramine when combined with fiber. You also want to add a nice multivitamin and mineral because you might be stripping those out because of these binders. You also want to help facilitate bile flow, so I like ox bile, and then supporting the liver with a little bit of N-acetylcysteine. You will do this as long as they need until they pass their visual test. And this could be a month, it could be 2 months, whatever it takes to get them to reduce their brain-related inflammation. Once you do that, you then swab their nose to detect the MARCONS. As I mentioned, it can live in the deep nasal passages. If present, you can treat with a prescribed medication, Bactroban and EDTA, or Bactroban, EDTA, and gentamicin. Or now we have access to an EDTA with silver compound formulation, which is showing some real promise. Once they clear their MARCONS, we then go to the gut. In the typical treatment sequence, this is where we diverge a little bit. It suggests checking for anti-gliadin antibodies. I think in our clinical population, we do better than that by assessing an entire food panel, looking at functional digestive aspects, and then we add some butyrate to the mix to help heal the gut lining and produce even more resolvins to reduce inflammation. So here we have the enterohepatic circulation that's occurring in this patient population. These patients just recycle those inflammatory proteins, so you need a stopgap, and the stopgap is a binder, either cholestyramine or okra. So cholestyramine is incredibly potent. Think of it as a glue. It's a negative anion binder with a very specific conformation for the receptor sites. This is why the charcoal, clays, chlorellas, zeolites of the world, unfortunately, don't work, because they are not charged appropriately. They don't have the right size binding site. So this is a little sciencey, but it's really important to understand that cholestyramine is unique in its capacity to bind these inflammatory proteins. It turns out okra does that, and there's also a little bit of activity with the phosphatidylcholine that I would suggest. Here's the study that compared okra to cholestyramine. This was a really well done scientific process, and when they combined it with the dietary fiber, they got almost half of the effects of cholestyramine. So I like okra quite a bit, 2 capsules, 30 minutes before meals. In addition to that, we have to treat the bugs in the nose, meaning a staph infection. These are slow growing. They do produce a biofilm, so you have to give a biofilm buster in addition to the antimicrobial into the deep nasal sinuses. Prescription takes at least a month, sometimes 6 weeks or longer, and the reservoir is damp buildings and even the noses of dogs. So here is the BEG spray. This is the formulation that many compounding pharmacies use, but you can also potentially give a silver EDTA as well, and we're beginning to see some nice activity with that too. So once the patient has passed their visual test, cleared their MARCONS, and you've worked on their gut, you then want to go on to their metabolic balance. And that is beginning a gentle detox process. I only start when their pH is above 6.5. Now you can add the chlorellas and clays of the world, give them some topical glutathione or N-acetylcysteine or however you want to do it. Once you started the detox process and you know they can tolerate it, I would then move on to hormone balance. In the traditional treatment model, it's just checking DHEA. I suggest doing a full hormone balance protocol using urine or saliva. Again, in this patient population, typically aromatase is upregulated, so I suggest chrysin and bilberry. And then go about the business of, do they need just DHEA, or do they need some full hormone balancing, which you could do with herbs. But if you can't get there with just the herbs, you may, and you don't do hormones yourself, I would suggest referring to a local physician who can help you with that process. Once you're getting their hormones into better check, we then start focusing on that ADH osmolarity abnormality. This is one of the only steps where, unfortunately, I've not found a natural substitute. We use desmopressin. This helps produce antidiuretic hormone, which is made in the anterior hypothalamus. It's given 0.2 milligrams every other night for 7 doses, and usually that kind of kickstarts the brain to work better. If you think about what we've done up until now, we've stairwise or stepwise reduced inflammation in the brain, proven by passing the visual test, in the respiratory tract by clearing MARCONS, in the gut by doing all of the digestive health related interventions, and then we start getting a little deeper in terms of removing toxins from the cell membranes, and now we can get after hormones. Right? So hormones are very hard to balance until you contain that inflammatory process, so BHRT in addition to antidiuretic hormone. And then finally, Once you're beyond all of that, you can get into resolution and repair. And that means dealing with the connective tissue issues, turning off the final aspects of the innate immune response, and then correcting the residual genomic changes and the brain-related abnormalities. So blocking MMP9, we institute a low amylose diet if the MMP9 is elevated. I also add in some boswellia because the boswellic acids are very good at reducing MMP9. Then we move on to remeasuring C3 and C4A. Typically by now the C3A is normal. If it's still elevated, you can use red yeast rice and CoQ10. If the C4A is elevated, we tend to go to high-dose fish oil in a 3-to-2 ratio of 2 grams twice a day. If you have not started the resolvins yet, you can also add in some resolvins. These labs hopefully normalize. And then we deal with the last inflammatory protein, which is TGF-beta1. This is a transcription factor. You can use losartan, which is a blood pressure med. If you don't want to use that, in the literature, it's been shown that bilberry and carnitine have also been shown to lower TGF-beta1. So once these inflammatory proteins have resolved, the MMP9, the complement, and the transcription factor, now it's time to do the final correction with the very special VIP nasal spray. This is an incredibly important peptide. We have known about it for a long time. It's a 28 amino acid sequence. It's actually produced in our bodies. It was originally indicated for treating pulmonary hypertension, but we know that it has these other effects in the body. It helps to regulate the immune system, and it helps heal the brain. It's extraordinary. And so we've done a series of studies to show in pre- and post-patient populations it helps to correct the underlying genomic changes as well as inducing upregulation of adult neuroprogenitor cells in the brain. So we have healing of the brain in addition to correction of the underlying genomics. This can take anywhere from 4 to 6 months or longer of therapy. Again, this is a nasal spray. Without it, we have a very hard time correcting the antidiuretic hormone and MSH completely. We also know that VIP can, because of its induction of MSH, helps to re-regulate the sex hormones. The dosage is 50 micrograms 4 times a day, alternating nostrils. And this can go on for anywhere from even 2 to 6 months or longer. We don't have great measures or markers of when a patient is done in VIP clinically. It's just when they feel like they're finally back to normal. We do tend to monitor specific proteomics in the visual test and consider stopping after the 6-week mark. Here's our data set on functional genomics looking at the transcriptome. We know that as we apply a stimulus across our genes, we have genetic expression. And we wanted to ask the question, well, what does that look like? And in this patient population, what it demonstrated, and this is 49 subjects, we collected data on pre and post for their transcriptomic profile, and the pre was pre-VIP. So these are patients that had passed their visual test, they had normalized their proteomic markers, they were feeling pretty good, but they weren't done yet because we had to resolve and repair their final injuries to the genome and their brain. So when we measured their baseline genetic expression, you can see in this graphical representation that they had surprisingly overexpression of many genes. So we looked specifically at the mitochondria. This is about 900 genes that we assessed. In our Lyme population, 500 extra genes were turned on inappropriately. And in our mold population, 700 extra genes were turned on inappropriately. So this was incredible to us that, as you look at the lexicon or vernacular around gene testing currently, and we said, oh, you're heterozygous or homozygous, and therefore you have a downregulation of this pathway or that pathway. It turns out that that's probably not the best way to look at genes and gene response, because if you are able to actually measure gene expression, which is what are the genes actually doing in real time, most chronic illnesses, and CIRS included, are actually showing upregulation or loss of regulation of gene response. That, to me, is extraordinary. And so most of the genes that we measured, you can see, are upregulated because they're coded orange or red. And the downregulation would be purple or blue. Then we gave patients the VIP nasal spray for 2 to 6 months, and we remeasured their genetic activity, and what do you think happened? Incredible. Downregulation of their gene response, restoration of regulation of DNA activity. This was extraordinary, that in fact we already had evidence that the brain healed, but VIP also induces normal genetic activity. This is true cure. So for patients that are so complicated in their initial presentation and so many things are wrong with them, as you go through this process of correcting their underlying inflammatory response, healing their gut, balancing their hormones, turning off that innate immune activity, you can also get to a final cure by healing the brain and healing their genes. So this decreased expression of these mitochondrial genes represents, I think, a real breakthrough for our area of clinical medicine. And so as a review, this is the biotoxin evaluation process. You do your initial screening. You want to verify that they're a biotoxic patient, that they meet criteria, all three: known exposure, differential diagnosis, ruling out other causes, and they meet criteria based on symptoms. In addition to that, 3 of 6, they fail their visual test, they have the genetic predisposition with their HLA on chromosome 6, and they have some other proteomic abnormalities, and then you confirm with therapy. You also are able to refine your diagnosis. I use the urine antigen test. You can also do the Western blot and ELISA, even though it misses most patients. You have them swab their home. You might have them do cardiopulmonary exercise testing. We scan their brain with neuroquant, and then in a small subset for research purposes, we do our transcriptomics. This is the standard treatment process. This is the general treatment process that I've expanded. So this is in the language, I think, of the integrative and functional provider, and you'll see extraordinary things happen. You will be able to fix patients that you weren't able to fix before. As long as you follow these steps and you understand one piece at a time what you're trying to do, and you don't get ahead of yourself and try and fix everything at once, and you watch these patients unfold beautifully, and you get to that last phase of resolution and repair. They're getting their energy back, their memory is being restored, their outlook on life is improved, and you said, boy, I just fixed one of my most complicated patients who had presented to me 10 years ago with chronic fatigue and fibromyalgia and atypical depression and weight gain and hormone imbalances and gut dysfunction and adrenal fatigue, and you said, wow, I didn't know that underneath all of that mess was this entity that had been quietly driving that abnormality for months and years. And to be very clear, this is a genetically mediated neuroinflammatory process that has secondary and tertiary consequences throughout the patient's physiology. So once you understand that piece, this is my guide for you to sort of weave through that world and begin to turn off each of those issues in a very specific sequence that we've been able to publish and articulate. So I know that was a lot. I hope that's helpful. I tried to be very specific for you. This is something that I know that you'll have to come back to in time and really sit with and think about and understand. It's probably for many of you a new language and a new approach, but I promise you if you walk through this door and you take a chance and you start ordering some of these labs and doing these therapies, you will be forever surprised at how many patients you can heal using this approach. So thank you for your attention, and I look forward to speaking to you again in the near future.
Thank you so much, Dr. Heyman. What a wonderful and informative presentation, really awesome science. Thank you very much. And thank you for taking a few questions. So let me begin with, what are the key features of diagnosis and treatment that every patient should know?
That's a great question. So the way I explain it, as a patient is beginning to wade into this world, and it's a idea and a language that they probably have not been exposed to, and they also have to understand that this is a multi-system, multi-symptom abnormality, that there is no single magic pill, a botanical, or pixie dust that's going to get them better, that there's a sequence of steps and therapies that we have to go through, and it's going to take them 12 to 18 months. But I always break it down into 3 categories for the patient. I say there are 3 foundational elements that we need to address to get you better. The first is answering the question and dealing with what's the exposure, and is it still present? Do we have to treat Lyme? Do we have to clean up your home? What are we dealing with, and is it still around? Now, it could have been historical. It could have been they've had Lyme and they've received lots of antibiotics and now they're just chronically inflamed. So you don't have to worry about that piece, but you always have to ask yourself the question, number 1, what's the exposure? Number 2, we have to turn off the inflammation. And I use that as code for all the steps that I reviewed, but to suggest that there's a series of treatments and therapies that we go through in a specific order. So we're going to go about the business of turning off that inflammatory response. And then the third piece is, even after you deal with the exposure, and turn off the inflammation. As I mentioned in our research, you're still left with brain-related changes and even genomic abnormalities. So we have to deal with the final phase of resolution and repair, meaning fix the damage. So the three pieces from my perspective for patients is deal with the exposure, turn off the inflammation, and heal the injury.
Thank you very much for that. And so where else can they go for additional information regarding CIRS?
There's a wonderful website called survivingmold.com, and I pulled some of the information from that website, especially in the proteomic markers and the normal values and descriptions of those markers in detail. I know I went over that very quickly, but if you want to sit with this and really read about what these different inflammatory proteins and neuropeptides do in the body, you just go to Surviving Mold. The traditional treatment algorithm is there. Links to how do I remediate mold in the patient's home is there, in addition to all sorts of supporting material, PDF files, additional research studies. It's a wonderful website. You're going to be spending a lot of time now going through all the different pages on the website. In addition to that, the visual contrast study is there. So that's where I typically send my patients. It costs them $15. It takes 10 minutes. So as I get them going, I send them to the website so they can do their visual test. They can gather additional information. They can read about the illness. It's all expressed for them on that website. So I think that is a single, wonderful, well-validated resource for patients that are curious about their illness.
Excellent. Thanks for that. And so we have time for one more question, Doctor. What else do we need to learn about this illness, and how will this new information likely change treatment?
I think that the undiscovered country continues to be the transcriptomics and genomics component. I think we've pretty much nailed and understood the proteomic and even organ-related changes. But as we continue to collect data on the level of the transcriptome, we are already seeing some surprising information that isn't quite ready yet for prime time. But one of the new features that we've been able to identify, for example, is a central insulin resistance in the brain that I think is probably adding to the weight gain component in this patient population, probably the memory loss and executive and cognitive dysfunction. We're also beginning to see overlap with other common illnesses. That maybe, for example, there's a direct relationship between a biotoxic event and the development of cardiometabolic disease, that the weight gain, endothelial dysfunction, hypertension, hyperlipidemia is not just because of lifestyle choices, that maybe we're overly blaming patients too much and even placing too much emphasis on some of those other interventions without really appreciating the degree to which infections and external exposures are beginning to play. So this is an exciting area where the genomics of CIRS is beginning to say something important about very common chronic illnesses like cardiovascular disease and diabetes. But this is sort of the early coming attractions. We don't fully understand the overlap and all the pathways that are being triggered. But I think over time, this is going to help us refine patients into various subcategories and help us focus our treatments even further as we move forward into the future.
That is just really something, Dr. Heyman, incredible information you've given us today. And I want to thank you so much for joining us. Unfortunately, our time is up. So this has been truly enlightening, and we invite our audience to learn more about your work at andrewheymanmd.com. And with that, I'll say good night to our audience and best of health to you all.